Thank you for watching the video. Now, I would like to I would like to welcome our very own Dr. Sheetal B. Nayak. Ma'am is an MBBS, PGDCC, DNB, and F Medicine, Joint Secretary of IACC, Vice President of IACC Karnataka State Chapter. She's Her present position is Joint Managing Director at Sri Tulsagiri Diabetes Hospital and Diabetes Research Foundation. She is also a consultant physician and clinical cardiologist at Sri Bhagyavanti Multispeciality Hospital, Vijaypur. She is also a faculty in various national, state, and journal conference. Ma'am, over to you.
Hello, good morning, all. I welcome you all on behalf of Indian Association of Clinical Cardiologists. So today we have our 5th monthly webinar on take-home messages for clinical cardiologists. The idea of these talks was basically we need not have to have need not have to be having a boring long lectures, and then at the end with the delegates feeling bored. So we thought of having some clinical interesting discussions, and then at the end we go with a take-home message which would really help people, doctors, with some help in their practices. So today we have two really good speakers. One is Dr. Islam Rashid, sorry. He is from Kuwait, and Dr. Syed Muzamil from Hyderabad. May I welcome Dr. Shafiq? Hello. May I welcome Dr. Mohammad Shafiq, who is the organizing chairman for and national president of International Association of Clinical Cardiologists, for the welcome address.
I welcome all the faculty, Dr. Ehsan and Dr. Muzammil, and all the delegates present here. Currently, I'm just dealing with a patient, so Dr. Sheetal, please take over.
I'll take over. So I'll be introducing the first speaker of the day, Dr. Islam Rashid. He has done his MBBS and his master's in cardiology, also his post-diploma in preventive cardiology. He's a member of various various societies from Egyptian College of Cardiology, and he also has a passion for teaching. His special interests are echocardiography, clinical cardiology, acute medicine, and especially COVID and non-COVID cardiology. Presently, we were discussing, he is working in the COVID cardiology department, and that's in Al Meri Hospital in Kuwait. I would like to welcome Dr. Islam for his presentation. He will be speaking on MINOCA and post-myocarditis. MINOCA is myocardial infarction in non-obstructive coronary arteries, and it remains a puzzling clinical entity characterized by clinical evidence of MI with normal or near normal coronary arteries or coronary angiogram. With cases now, majorly we are dealing with most of post-COVID complications, and this post-COVID myocarditis remains a puzzle for many of us since this is a new disease. I hope that Dr. Islam would enlighten us in this. Over to you, Dr. Islam.
Thank you so much for this great arrangement, and thank you for inviting me today to this great project that you are taking care of. Let me just put it in brief. We'll present a real case that we faced in our practice recently. Then we'll go to the discussion. Okay. Shall we start?
Yes, please.
Okay, our patient is a 42-year-old male from Bangladesh. He was not vaccinated for COVID-19. He was previously healthy, non-smoker, no past medical history. He has also no family history of premature coronary artery disease, no medication or allergies. He presented to our casualty on 2nd of May, diagnosed with COVID positive at another hospital, and he was given home instruction for isolation and some OTC. However, he had several bouts of cough, fever, sweating, and general fatigue, and he was taking paracetamol with no or little improvement. Again, he presented to ER on the 10th of May with 3 days history of chest pain. His pain was on and off for the past few days, reached maximum intensity 2 hours before ER presentation. His pain also was compressing central and radiating to the neck. It was associated with SOB, sweating, but yes.
Excuse me, sir, your screen is not visible.
Sorry.
Can we
Yes.
please restart?
Yes. Okay. Okay. Shall we
Yes,
start
visible.
again?
Yes, visible, please.
Okay. So again, back to our patient. He's 42-year-old male from Bangladesh with no past medical history. He was diagnosed as COVID positive on the 2nd of May. He took some OTC medication and was given home isolation instruction. But again, he had chest pain and again presented to our casualty on the 10th of May, like 1 week before his diagnosis of COVID. He had 3 days history of chest pain, which was typical for angina. In ER, the patient was stable, conscious, and oriented. His examination was unremarkable, but his chest pain was 7 out of 10. Few scattered wheezes on the lung. Otherwise, everything was fine. His pulse, blood pressure, and oxygen saturation also were normal. This was his X-ray in ER. You can see the bilateral infiltrations. Heart size is almost okay, but there is bilateral infiltration on the. This was his ECG in ER. You can see that there is ST elevation in lead 2, lead 3, and the AVF, small Q waves. Also, there is some lateral elevation from V5 to V6, some ST depression also in AVL. This is the posterior leads. You can see also subtle elevation from V4, 5, 6, which represents the posterior leads. And this is the right leads. Also, there is subtle elevation also in the right leads. So at the moment, STEMI diagnosis was suspected. Patient was loaded with aspirin and Plavix. He was given some GTN and IV heparin and was not, shifted to cath lab for primary PCI with full PPE. Then, what do you think his coronary angiography revealed? His coronary angio was completely normal. So at this time, we did not have any explanation for the presentation because, as you see, ECG is typical for STEMI. His chest pain also is typical for STEMI, but still his coronary angio is normal. So myopericarditis was a possibility, and thrombosis with spontaneous recanalization also was a possibility. You can see here also his coronary anatomy. This is the ECG after finishing his coronary angio. Also, there is some decrease in the ST segment and the inferior leads, and the patient was almost asymptomatic apart from some mild cough, but no chest pain. This is the X-ray. So bedside was done after coronary angio, but unfortunately I can't get a record of the study. But at that time it showed mild global hypokinesia. His ejection fraction was around 45 to 50%. There was no significant valve lesion, no mechanical complication, but a minimal circumferential pericardial effusion. His lab results, CBC, RFT were normal. CRB was slightly elevated, 17.5. Then again, it came down. D-dimer was okay. Lactate was borderline. Otherwise, INR, LFT, VBG were all normal. His troponin on presentation, it was 7. Then above 27, this is the maximum for lab here. Then again above 27. Then it came down to 17, then 13, then 4. It's also a pattern of myocardial injury. And accidentally, we found that his HbA1c was 12.5. He has no history of diabetes and no past medical history. But it's also good point to teach that all patients are admitted for ACS. We should screen for thyroid by TSH, diabetes by HbA1c, and we do lipid profile to detect also familial dyslipidemia. So in all ACS cases, we are doing this like routine. And surprisingly, we are catching too many people with diabetes, too many people with thyroid, and also some people with familial dyslipidemia. Blood culture and urine culture were clean, but this patient had sputum positive for Klebsiella pneumonia, which was sensitive to cephalosporin. His ProBNP was also borderline, like 800. Other lab were normal. Patient was admitted to our CCU and according to our isolation protocol. He was diagnosed as having MENUCA. This is our topic today. Mostly myopericarditis versus coronary artery thrombosis with spontaneous recanalization, both as a consequence of COVID-19. He was managed with aspirin, Plavix, colchicine, together with statin, ACE inhibitor, beta blockers, proton pump, and he was kept on Plavix with plan to be stopped after cardiac MRI confirms the diagnosis of myopericarditis. Sputum culture was positive for Klebsiella, which was treated with antibiotic. And we consulted also our respiratory colleagues who advised for CT chest. It was postponed until 48 hours after acute admission. You can see this is his CT. Also, it is interesting to see his CT. You can appreciate also the bilateral infiltration. However, because the patient had no past history, his lungs was okay. So he did not have desaturation during his whole hospital course. You can see also the radiologist here commenting COVID-19 pneumonia, CORAD score 6. CORAD score 6 means he has all the typical signs for the CT for COVID, plus he has PCR positive. So this CORAD score is helpful when it is 1 or 5. So 1, there is no finding suspicious of COVID pneumonia, and 5 is highly suspicious. 2, 3, and 4, there will be debate between doctors whether this patient is having COVID pneumonia or not. But once patient is having score 5 plus PCR, this is 6, so this is the highest possibility for the COVID-19 CT pneumonia. After antibiotic treatment, his lungs improved and cough decreased. This is his X-ray before discharge. So again, I put here the CT finding just to appreciate what will be the picture in COVID-19, typical COVID-19 pneumonia. Bilateral multifocal, so it is bilateral, not unilateral, multifocal, mainly peripheral ground glass opacities. So it is bilateral, it is multifocal, and it is peripheral. So pulmonary edema will come from the center, from the heart to the periphery, while COVID will start from the periphery. There is also marked patchy consolidation with subpleural bands. Also, it will start from the pleura and subpleura. So this is typical of COVID-19 pneumonia, CORAD score 6. There is also here, you can see mild cardiomegaly, minimal pericardial effusion, which was already seen by echo. So this is the medication that the patient received: aspirin Plavix for the ACS, colchicine for myopericarditis, Lipitor, Concor for heart failure or ischemia also, tritase, low-6-ceftriaxone, and doxycycline for COVID pneumonia. And fortunately, it was also covering the Klebsiella, vitamin supplement, paracetamol, cough syrup, and heparin prophylactic, Lantus and GTN. So patient was discharged home in good health and stable condition and almost asymptomatic. He came back for follow-up later on, and his echocardiography was repeated, which was completely normal with good LV ejection fraction, no motion abnormalities or pericardial effusion. He was planned for cardiac MRI, but it was not done because of some financial problems. This is the echo on follow-up. You can see it's completely normal. Even you cannot know that this patient previously had any myocardial insult. This is the ECG also on follow-up. The inferior leads showing some T-wave inversion, but no ST elevation. Lateral leads are okay, and there is no ST depression at all. So our topic today is to answer this question: when a heart attack is not a heart attack. When the patient presents with a heart attack, but finally you discover that this was not a heart attack. So what was this? Okay, so is it COVID-related, minuca, or myocarditis? So we know that COVID is a disease primarily of the lungs and heart. It starts with early infection, then after that pulmonary phase, then after that there is cytokine storm and hyperinflammation. So you can see from the left to right, here the first 5 days, there will be like viral prodrome. Then after that, the virus will go to affect the lungs. It will cause some abnormal chest imaging. Then at day 7 to day 10, most people will recover, but some people will have like extraordinary response to the virus from the immune system with cytokine storm, which is responsible for most of the critical scenarios that we are seeing, either damage of the heart, damage of the lungs, or damage of somewhere else in the body. So you can see here, cytokines will cause some oxidative stress and endothelial dysfunction. This will cause microangiopathy and small thrombi. This is also responsible for raising the D-dimer, and this is the value also of checking D-dimer in such patients. So once you find D-dimer is high, this means there is also huge cytokine storm. And just to remind you that cytokine is like the weapons of the immune system. Immune system is feeling attacked by the virus, so it is trying to clear it up, to disinfect this virus. So cytokines are secreted, and in moderate amount, it is helpful. But if it exceeded the normal levels, it will cause damage both to the host and the virus itself. So this also, cytokines will cause myocarditis, inflammation of the cardiac muscle, and also it can cause some endothelial dysfunction and plaque instability. So for normal people, they can have some vasculitis. And the people with stable plaques can rupture and cause ACS also. So here also we can understand why the incidence of ACS with normal coronaries increased during the era of COVID, because these people, sometimes they are having stable plaques, like 50% stenosis or less, while they are infected with COVID-19 with cytokine storm. This plaque will rupture, causing transient occlusion of the vessel. Then after imaging, you see the vessel is okay. Already the plaque has ruptured and thrombus has occurred, but it was cleared from the bloodstream. So here again, you see there is early stage and late stage. Early stage of COVID, there will be flu-like symptoms, then lung localization, then the immune system will get prepared for this virus. So either it will pass easy with no overreaction from the body and then healing, or the hyperinflammatory state will cause cytokine storm and the prothrombotic state. So this cytokine storm is responsible for the order lab finding, and the prothrombotic state is responsible for what we are seeing also too much cases from DVT, BE, and sometimes DIC. Again here, confirming this concept that COVID-19 will cause also type 1 MI. This is like coronary thrombosis, like before days. And also it can cause hypoxia, which will affect the heart and elevate the troponin. Again, it can cause sepsis from secondary bacterial infection, which will elevate the troponin, systemic inflammation, pulmonary thrombosis, and embolism, and stress cardiomyopathy. We also get too many consultations from other specialties during the COVID era. Too many patients, almost all patients admitted for any reason with COVID, we are consulted for elevated troponin. So this is the explanation why troponin will be elevated in such patient, even if they are not having any cardiac insult or any chest pain, no ECG changes, but troponin elevated with COVID. This can explain. These are the mechanisms that COVID can cause positive troponin. It is also good to remember these mechanisms. So here, myocardial injury can be caused by many mechanisms by COVID. So COVID can cause ACS, it can cause cytokine storm, it can cause direct myocarditis, and also drug therapy can cause some myocardial injury also. Again, re-emphasizing these concepts. So myocardial injury, MI, microinfarct, in some people, ventricular fibrosis and atrial fibrosis causing arrhythmia, AFib, VT, cardiomyopathy later on. Here also you can see, so COVID can cause myocardial injury, myocarditis, ACS, it can precipitate heart failure, it can cause thromboembolism anywhere in the body, especially in some patients, it will come like abnormal site. We have seen patients with subclavian thrombosis, which is very rare. He doesn't have any previous history of thrombosis, no family history of thrombosis. There is no central line. There is no reason that he should get subclavian thrombosis. He was tested negative, but after having subclavian thrombosis, we checked his COVID state. It was positive, and this explained to us why the dimer is high, why this patient is having unusual site of thrombosis also. So COVID also can cause arrhythmia and myocardial injury. Again, this is the link between COVID-19 and the cardiovascular disease. When COVID started spreading like 1 or 2 years ago, it was identified as a flu or respiratory virus, but now it is known as cardiorespiratory virus. Not only respiratory, but in cardiology, it shares like 50% of its damage is related to the heart. The other 50 is related to respiration. And together, they will cause mortality and morbidity. Otherwise, in mild cases with no heart affection or lung affection, it will pass like usual flu. This also a slide presenting the lab abnormalities that you can see in COVID positive patient. So this is biochemical monitoring in severe COVID-19. You can see elevated white count, neutrophil, BCT, ferritin, procalcitonin, and ESR. You can see also that AST, ALT are high, gamma GT also is high. in some cases troponin and proBNP, D-dimer in most cases, sometimes also renal function affected. So again, what is the typical progression of COVID-19? This is also good to know and emphasize to ourselves and to our patients, because almost everybody will get infected with COVID, or someone you are taking care of, someone you love will have COVID at some point, because now it will be like spreading and infecting everybody. So it is good to know the typical progression. Once infected, it will take 2 to 14 days, like incubation period, average is 5 days. 80% of cases will be asymptomatic. The other 20%, some of them will have mild symptoms, the other will have severe symptoms. So once symptoms arrived, it will take like 1 or 2 weeks for complete recovery. But in some patients, around day 5, starting difficulty of breathing. So this is very important. If someone got infected with COVID, day 5 to day 7 are very critical period. Patient who deteriorate will start deteriorating from day 5. If day 7, no SOB, this patient almost will be asymptomatic and it will be mild infection only. But at day 5, if he started SOB, this red flag that this patient should be hospitalized and we should put him on close monitoring. So day 7 to day 11, usually patient present to hospital, like our patient, the case we presented, he came on day 7 with 3 days history of chest pain at SOB. So this typical case. Then at day 12, some patient will get admitted to ICU. 5% of cases are critical. Some of them will die. Some will survive until hospital discharge, like after 4 weeks. So this also the typical progression that we should all be aware of. So again, back to our patient and presentation. Patient presented with what looks like heart attack. Then angio said it is not heart attack, or there is no coronary obstruction. So what is the explanation? So in the guidelines, there is a new term called MINUCA, myocardial infarction with non-obstructive coronary artery disease. This to differentiate this term from STEMI. So STEMI, there is myocardial infarction with obstruction of coronary artery. However, if the presentation looks like STEMI, but there is no obstruction, it is called MINUCA. So MINUCA is a broad term. Like you classify acute coronary syndrome to STEMI and non-STEMI and unstable angina. So STEMI itself, if there is coronary obstruction, it is done, it is STEMI. If there is no coronary obstruction, this new term arises. You can see here, this is troponin positive non-obstructive coronary artery disease or myocardial injury. So there are cardiac causes, there are extra cardiac causes. Again, also we highlight the importance of knowing the other causes that would elevate the troponin, because you will get many consults for troponin positive. Only troponin positive, there is no chest pain, no ECG changes, no cardiac history. Patient is feeling okay, but he's admitted for some reason under respiratory, for pneumonia, under medical, for some other infection. So pulmonary embolism also will cause troponin positive, sepsis will cause troponin positive, stroke will cause troponin positive, and ARDS also can cause positive troponin. So this is the workup for MINUCA. First, you suspect MINUCA, then you work up to reach the final diagnosis. So when we suspect MINUCA, from the guidelines, in 1 to 14% of MI patients, there is absence of coronary artery disease. The demonstration of non-obstructive coronary artery disease in patients presenting with symptoms suggestive of ischemia and ST elevation or equivalent does not preclude an atherosclerosis etiology. MINUCA is a working diagnosis and should lead to treating physician to investigate underlying cause. The identification of MINUCA, of underlying cause of MINUCA, should lead to specific treatment strategy. Although the outcome of MINUCA strongly depends on the underlying cause, its overall prognosis is serious. with around 1 year mortality of 3.5. So again, you suspect STEMI, this is an ER. You see a patient with typical chest pain, ECG is typical for STEMI, you shift him to cath lab. Then after coronary angio, if the patient is having coronary artery stenosis more than 50%, this is a STEMI, classic. You don't need to worry about the diagnosis or treatment. You know everything. Okay, if you find coronary artery normal or less than 50% stenosis, then you will suspect Minuca. You can write in your sheet or diagnosis, this is a case of Minuca for further workup. Some people at this time in cath lab will do LV angiography, LV ventriculography to identify also if there is Takotsubo or something. Some will wait for cardiac MRI or echo. So again, here's the diagnosis of Minuca is made immediately upon coronary angiography. Some will ask also, how you know from ER this patient STEMI or Minuca? We don't need to go to coronary angio if he is Minuca. No, there is no other way to know if this is STEMI or Minuca unless you do coronary angio. So in ER, you will treat all like STEMI. Then after coronary angio, if you have normal coronary or less than 50%, this is Minuca. If you have more than 50%, this is STEMI. If it is STEMI, you are done. If it is Minuca, you have to proceed further to specify the cause. So what are the suspected causes? It can be myocarditis. How you will know? Transesophageal echo, and then later on cardiac MRI. Endomyocardial biopsy also is there, but its role is very limited because it is invasive, it has complication and risks, and it is reserved for very sick patient who cannot do cardiac MRI and in whom the diagnosis will change their management. Microvascular disease also, you can know by echo, you can know also by cardiac MRI, you can do IVUS during the coronary angio, and some provocative tests. So Takotsubo also you can see by cardiac MRI and echo, pulmonary embolism, D-dimer, CT pulmonary, and thrombophilia screen. Type 2 MI, supply-demand mismatch. From the clinical scenario, you can suspect in patient with anemia, severe sepsis, severe tachycardia, and some toxic myocardial drugs. So the spectrum of acute COVID-19 cardiovascular symptoms has a wide variety of range. You can see like 7 or more clinical scenarios. Patient can present with ACS, can present with myocardial injury without coronary artery stenosis. This is Minuca. He can present with arrhythmia, either atrial or ventricular. Most commonly is atrial fibrillation. Patient can present also with heart failure exacerbation on top of chronic heart failure. He can present with pericardial effusion and tamponade, and some will present with pulmonary thromboembolism. So 7 or more clinical presentation you can see from cardiac point of view in COVID patient. Here also another interesting case. It's a 55-year-old female presented with the sudden onset of chest pain for 2 hours. Pain was typical, troponin elevated. You can see here also ECG. There is ST elevation, chest leads. Coronary angio showed no significant coronary artery stenosis. Her D-dimer was normal, and left ventriculogram was normal. So this patient was labeled in the diagnosis as Minuca. So what is the cause of Minuca? What is the etiology? After checking thrombophilia screen were normal, intravascular IVUS was normal, provocative test normal. Cardiac MRI showed that this patient is having subendocardial injury, myocardial infarction from microvascular disease. So what does the guidelines say? In 2020 non-STEMI guidelines, there is recommendation in all patients with initial working diagnosis of Minuca. It is recommended to follow diagnostic algorithm to differentiate true Minuca from alternative diagnosis. It is recommended to perform cardiac MRI in all Minuca patients without an obvious underlying cause. It is recommended to manage patient with an initial diagnosis of Minuca and final established underlying cause according to the disease-specific guidelines. Patient with a final diagnosis of Minuca of unknown cause may be treated according to secondary prevention guidelines for atherosclerotic disease. This is also re-emphasizing this concept. Here you can see cardiac MRI in myocarditis and myocardial infarction, which are the most common things that you will face. So either it will be subendocardial infarction or myocarditis. So infarction tend to come from inside the heart, from the endocardium, subendocardium, while myocarditis will affect the mid-zone or outer. So usually it is associated with pericarditis. So it will be myopericarditis. It will come from outside to inside. So myopericarditis, it will affect the pericardium, outer and the middle layer, while infarction will start from inside the heart, affecting endocardium and up. And here you will have some dilemma in shifting such a patient to cardiac MRI. So this is a typical ICU patient, very sick, on maximum support, and you suspect myocarditis. Can you shift him for cardiac MRI? Unfortunately, no, because it is very dangerous to shift for the patient and also for the machine. The machine will get corrupted by this. You can see here the magnet inside the cardiac MRI machine will get attached to any metal, even the patient bed or wheelchair. So sometimes you need to worry which investigation you are going to do next for your patient, for his safety and for everybody's safety. Quickly, we'll review. This is myocarditis. You can see here redness, hotness, and swelling. The normal myocardium, there is no inflammatory cells, but when the patient gets myocarditis, there is too many inflammatory cells. Again, you can see here under microscopy, no inflammatory cells and myocarditis. Even myocarditis itself, there is fulminant and there is acute myocarditis. You can see also in fulminant myocarditis, there are too many inflammatory cells than in regular myocarditis. This is also helpful because in fulminant myocarditis, your biopsy will give more information than in regular myocarditis. I will not go in depth through the etiology, but I will leave the lecture at the end. You can also review these details. Okay, so it is also important to emphasize that all patients with myocarditis should be followed with clinical assessment, ECG, and echocardiography, and also even more on long term. So now you are faced with patient with suspected myocarditis. What you will do biopsy or cardiac MRI. If the patient is acutely unwell, then you stabilize and you prepare for endomyocardial biopsy. But if the patient is stable, you just proceed for cardiac MRI after discharge. So again, patient with myocarditis, stabilize hemodynamics, treat as heart failure, treat any arrhythmia. If he is unstable, you will put some support, inotropic support. And if you suspect that the cause of myocarditis will affect the management, then you do endomyocardial biopsy to diagnose like giant cell myocarditis or so. Otherwise, you treat as regular heart failure and arrhythmia. This is how you take endomyocardial biopsy. Also, it is invasive maneuver with also some risk to such sick patient. So myocarditis, this is the practice steps. Most common cause of myocarditis is viral, and there is no benefit to know which virus. Previously, there was some recommendations that you do virology screening. Now it is not recommended to do virology screening. So if you suspect the virus, it is virus. Treat as heart failure. Safe, sensitive, and non-invasive diagnostic test to confirm myocarditis is not yet available. And here is the problem. The diagnosis is challenging because the clinical presentation is non-specific. Patient will present with either ACS scenario or heart failure scenario. There is no specific symptom or sign for myocarditis. Even ECG, there is no specific sign of pericarditis, no specific lab also for myocarditis. And also the clinical presentation is highly variable. Some will present with just like SOB, some will present with fulminant myocarditis and cardiogenic shock. Cardiac MRI looks promising for diagnosis as well as establishing and discriminating myocarditis from myocardial infarction. As we said before, myocarditis mid-wall, while infarction will affect the inner aspect. Endomyocardial biopsy is the gold standard, but only reserved for select patients which are fulminant cases or cases associated with conduction disturbance and malignant arrhythmia to rule out giant cell myocarditis. Cases unresponsive to standard antiviral therapy, anti-heart failure therapy. So again, virology screening is no longer recommended. Prognosis of myocarditis, a rough rule of third applies here also. 1/3 of patients will recover completely, 1/3 will die or require transplant, and 1/3 will have residual LV dysfunction. Bed rest, aggressive supportive therapy is the mainstay due to high incidence of recovery. The core principle of treatment in myocarditis are optimal care of arrhythmia and heart failure. So you don't need to know anything extra to manage a patient with myocarditis. If you suspected, you treat heart failure well, you treat arrhythmia well, then your patient will get well soon, inshallah. So ABC's standard heart failure therapy seem to benefit myocarditis patient, except digoxin, which is contraindicated in the acute setting due to high risk of arrhythmia. Also, should know that beta blocker should not be used or at least used with caution in the acute setting. Later on, you can introduce beta blocker freely, but in acute setting, if you started, you start low dose and keep an eye on your patient. Otherwise, you can wait for 1 or 2 days until you make sure that this patient is not going into cardiogenic shock. Then you introduce your beta blocker. Immunosuppressive therapy does not improve survival and is not routinely used in the management. Fulminant myocarditis often present with non-dilated second hypocontractile LV. So in echo here, there is, because no time for dilatation and there is severe inflammatory process, so there will be edema in the heart. The ventricles will not be dilated, even it will be thickened more because there is no time for dilatation and there is too much edema. Most common ECG finding is sinus tachycardia and non-specific ST and T wave changes. In some patients, they will present with pseudo-infarction pattern, like our patient with some ST elevation, some with Q waves also. Okay, finally, we'll just talk about myocarditis from COVID vaccine. There has been also some reports after starting vaccination with Pfizer vaccine to people to the age group below 30. There were some reported cases of myocarditis. So shall we continue vaccination or this will be the limit for vaccine for such age group? By numbers, for every 1 million case of vaccination, there is follow-up. You can see here the risk and the benefit. So 8,000 cases prevented from COVID, like 200 hospitalization prevented, 38 ICU admission prevented, and 1 death prevented for 8 to 10 cases of myocarditis. You can see also in males numbers are slightly elevated for myocarditis, but also the numbers of infection prevented is much more than myocarditis case. Even here with bigger figures, you can see that in 1 million, only you will get like 10 cases, 20 cases of myocarditis. However, you will prevent thousands of this, hundreds of hospital admission, and tens of ICU cases and mortals. So we should proceed with our vaccination, but just take care in the age group below 30, especially in men. The incidence of myocarditis related vaccine in women is very low. So you just vaccine men and women and keep an eye after vaccination. If any symptom, patient will get admitted and treated accordingly. So take-home message, Minuca is a working diagnosis like heart failure and anemia. Once you say heart failure, you have to know the cause. Once you say anemia, what is the cause of anemia? So again, if you said Minuca, what is the cause of Minuca? So this should lead to further workup. It is important that we become familiar with this syndrome with different clinical scenarios and presentation so that each patient will receive appropriate tailored therapy while the overall prognosis of Minuca is better than acute myocardial infarction. However, some variability in between causes also. Management of Minuca is based on limited evidence, and there are no prospective randomized controlled trial. So the best approach is individualized treatment according to the underlying mechanism. And thank you so much. Thank you.
Thanks a lot, Dr. Rashid.
Thank you. Thank you, Dr. Rashid. That was an excellent presentation. That was an excellent compilation of cases related to post-COVID myocarditis and Minuca. It would definitely help many of us now that we are seeing most of post-COVID complications and myocarditis as well. So let me see if we have any questions. We don't have any questions. Any questions from the faculties? Okay, if nobody has a question, I'll have one actually. I wanted to know what are the recommendations for antiplatelets post-COVID, and do these really help in prevention of myocarditis as primary prevention or secondary prevention?
Yeah, a really nice question. Regarding antiplatelet, there is no role for antiplatelet in COVID itself. Okay, so COVID patient without ACS, there is no role for aspirin. Previously, it was recommended to give low dose aspirin, but currently, after trying aspirin, after trying full dose anticoagulation and the prophylactic anticoagulation, the final recommendation now that we give in the middle, we give prophylactic, not therapeutic and not aspirin. Aspirin will not prevent VTE. However, it decreases the risk, but it is not the optimum. So the optimum way to go is prophylactic anticoagulation. So any hospitalized patient for COVID, he should receive prophylactic anticoagulation. Okay. But cardiology patients, suppose we admitted one patient with acute coronary syndrome and COVID. Usually in this scenario, we give full anticoagulation, not because of COVID, we give it because of ACS. Okay. But if the patient is admitted for some other reason like pneumonia and COVID, he will get prophylactic anticoagulation. Some colleagues also recommend aspirin for outpatient. Like some of the colleagues will ask you, my mother is obese and she's having COVID. She has no symptoms, but I am worried. Okay, you can give aspirin. There is also some evidence that aspirin in general prevent the incidence or decrease the incidence of DVT and BE. There is like 15% to 20%. So it is better than nothing. And also you cannot recommend that all asymptomatic patients out of hospital to get anticoagulation. This will be also too much harm for them because you will get more bleeding than expected. So asymptomatic patient, if you recommended aspirin, it's okay. Hospitalized, you give prophylactic. If the patient has other indication for false therapeutic anticoagulation like AFib, ACS, pulmonary embolism, then you go for therapeutic. I hope it is clear.
Yeah, so I take it as if you don't have any other comorbidities, don't give aspirin just because it's a post-COVID patient.
Yeah.
Okay. Yeah. Let me see. I think I have two questions. Please, Dr. Atul Kumar is asking, please explain treatment strategy for pregnant Minuca patients in COVID-19.
Sorry, I cannot get this.
Can you
explain
for treatment strategy for pregnant Minuca patients?
Yeah. See, as we said earlier, Minuca is a broad term. We have to identify what is the cause. If the patient is pregnant, we can suspect that this is peripartum cardiomyopathy. Then you will proceed for treatment of heart failure in pregnancy. Heart failure treatment in pregnancy is like in usual population, apart from some medication restriction due to pregnancy and lactation. Like amiodarone, if the patient needs amiodarone for asthma, ACE inhibitor, you cannot give. However, and statin also you cannot give. So you can give beta blocker, you can give aspirin if you need, you can give diuretics with caution. So if the patient is pregnant and having Minuca, there is also some cases reported of spontaneous coronary artery dissection in pregnancy. So the patient can have Minuca from spontaneous coronary artery dissection. This you will know, you will diagnose by angio only. You cannot know by any other means. So you do coronary angio, you will find that this patient is having spontaneous coronary artery dissection, and the treatment is conservative. So it depends upon the etiology of Minuca in pregnancy. If the patient is having myocarditis, bed rest, and failure measures. So we have to identify the etiology of Minuca in pregnancy and non-pregnancy. As we said, more than 7 scenarios are there. Each scenario has different treatment. If it is ACS, you will give anti-ischemic. If it is myocarditis and failure, pericarditis, you will add colchicine. So we have to, if type 2, like severe anemia, also you have to give blood or blood product to correct. I hope also the answer is clear. Thank you so much. So also one question regarding thrombolytic in COVID patient. It is simple. If you have primary PCI, you will proceed for primary PCI with full PPE. This is our protocol here in Kuwait. We have primary PCI 24/7. So once the patient presents to the STEMI, earlier the people were too much afraid to get infected. So at some point in this journey with COVID, at some point they stopped because many people in CASLab got infected early. They stopped all primary and they recommended thrombolytic. But after like 1 or 2 weeks, they started again to work with full PPE. So now, if we are receiving one patient in STEMI in ER, I have primary PCI, I will notify the CASLab. I am suspecting that this patient is positive. Take your full precaution and do coronary angio. This is the best option. This is the best option with the best outcome, which will decrease the heart failure and the patency of coronary artery in more than 70% of cases. While in thrombolytic, it will be like 30 to 40%. Then you will have to do angio again. It is long dilemma. So better if you have primary PCI, proceed for primary. Okay. Thank you so much. Thank you. Sorry, I cannot.
Sorry, I'm sorry. Yeah, Dr. Gyanendra Singh had asked the same question. Is it recommended to thrombolize in acute STEMI setting? So yeah, like you said, we can go ahead with it. Okay.
You can go ahead if you don't have primary PCI, but if you have primary PCI, you go for primary with full PPE. This is the best option.
Okay. Okay. I think you have answered all our questions. Thank you, Dr. Reslam Rashid, for the excellent presentation. Thank
you so much.
Yeah. Thank you so much. Shall we proceed to the next talk? So the next talk is by Dr. Syed Muzammil. He is an MBBS and PGDCC. He's a clinical cardiologist from Apollo Hospitals, Hyderabad, and he's an associate consultant in Department of Cardiology, Uday Omni Hospital at Hyderabad. Today, he would be speaking about DVT and pulmonary embolism, take-home messages based on cases. Personally, he is one of our favorite teachers, and we look forward to more of enlightenment from him. Over to you, Dr. Syed Muzammil.
Thanks a lot, madam. Thanks a lot for my wonderful introduction. So, am I audible now?
Yes, you're audible. Okay.
I thank Indian Association of Clinical Cardiologists for giving me this opportunity to present this presentation in front of you all wonderful doctors. So let's start with the presentation. Are my slides visible, ma'am?
Yes, your slides are visible, sir.
So my presentation is regarding deep venous thrombosis and pulmonary thromboembolism. So I will start with real life case scenarios. Case number 1 is a 39-year-old male patient, non-diabetic, non-hypertensive, He suffered fracture right neck of femur due to road traffic accident. He unfortunately contacted a local quack and he was kept immobilized for 25 days in the home. Now he came to hospital for fracture fixation as he was unable to walk despite the quack telling him that he would be walking after 25 days. So he came for fracture fixation, but he was having right-sided chest pain, breathlessness, and palpitations since 3 days. This was a new symptom that he had. His vitals on arrival were pulse 117 per minute, BP 110 by 70, saturation was 110, 92% on room air, ECG was sinus tachycardia with no STT changes. Echo showed tachycardia during study, normal size cardiac chambers, no RWMA, and good LV systolic function. So this was his X-ray. You can see in X-ray, the right base opacity is there. So considering his unexplained sinus tachycardia, tachypnea, saturation less than 94% on room air, as well as right-sided opacity in the chest X-ray, prolonged bedridden status, it was suspected that he must be having deep venous thrombosis which progressed to pulmonary thromboembolism, causing pulmonary embolism. So bilateral lower limb venous Doppler and CT pulmonary angiogram was done to him. The CT pulmonary angiogram revealed that he had right-sided subsegmental pulmonary embolism along with pulmonary infarction. So the X-ray opacity is nothing but pulmonary infarction. Surprisingly, left lower limb venous Doppler was negative for DVT, indicating that the whole thrombus got embolized in him. So case number 2 is a 65-year-old male patient. He was hypertensive diabetic. He had bilateral osteoarthritis of the knees. So he was advised a total knee replacement for the both knees and surgery was done. It was uneventful. But unfortunately, the anticoagulation was not given to him. It was by mistake omitted in from the discharge summary. He came to hospital after 15 days with breathlessness and low saturations. Bedside echo revealed that he had dilated RARV, D-shaped left ventricle, moderate pulmonary arterial hypertension, dilated IVC, which was non-collapsing with respiration. Bedside bilateral lower limb venous Doppler revealed that he had DVT of the operated leg. CTPA confirmed the presence of pulmonary embolism. Case number 3 is Mrs. PQR. She was a lady from Hyderabad. She went to Kedarnath Yatra at Kashmir and she had a road traffic accident and she fractured her tibia. She came to all over Hyderabad for fracture fixation. Her surgery was uneventful, but after 20 days, she came with DVT of the operated limb. She was on Clexane for DVT prophylaxis and she developed heparin-induced thrombocytopenia thrombosis, which was the reason for DVT. She was treated with fondaparinux and later she was discharged on dabigatran. So we are seeing this many cases where this DVT and pulmonary is quite common. Previously, it was not detected that, but now the imaging modalities, Doppler as well as CT pulmonary angiogram have arrived and they are rampantly available everywhere. So we are getting more and more diagnosis of DVT and pulmonary embolism. The last case is case number 3. He was a 55-year-old male patient. He was constable by profession in the police. He was known to have pulmonary cox, but he was drug defaulter and he was on ATT. He was not feeling well since 1 month. He was lethargic and having malaise. He developed overnight swelling of his left lower limb, which was painful. ER physician have done the bilateral lower limb venous Doppler, which revealed acute DVT. According to NICE guideline, if you encounter any patient above 40 years of age without any obvious precipitating cause of DVT like limb injury, fracture, or bedridden status, then search for occult malignancy. So his routine investigation revealed that HB was 5.8. Upper GI endoscopy was done, which revealed large ulcer in the stomach. The biopsy of which revealed gastric carcinoma. So these are 4-5 cases that I presented where DVT and pulmonary embolism was the diagnosis. So come to our talk. Venous thromboembolism constitute two clinical entities, that is DVT and pulmonary embolism, both having the same pathophysiological process. Pulmonary embolism has been declared as the most common preventable cause of death. DVT and pulmonary embolism survivor, if they survive, they can develop complications like post-thrombotic syndrome, chronic thromboembolic pulmonary hypertension. These issues can happen. So what is the pathophysiology of DVT? So we have all read Virchow's triad in second year MBBS that in the vessel, if there is stasis of blood, if there is hypercoagulability of blood, and there is injury to vessel wall, the triad of Virchow is completed, and this leads to development of deep venous thrombosis. So DVT pathophysiology, here you can see the normal blood flow in vein. These are the deep veins in the leg. So they are surrounded by the muscles, right side, left side. And as the patient walks and does activity, these muscle compress these veins, and blood from lower side is pushed towards the upper side. And but the blood cannot go back because of the valve. And by this, the blood is flowing from against gravity towards the heart. But in DVT, the patient developed some issues like critical illness or fracture, or there may be some use of oral contraceptive pills or hormone replacement therapy. This make the patient bedridden due to some reason. They develop stasis of blood, and this blood gets clotted. And it is formed as DVT. It is called as deep venous thrombosis. So, what are the acquired risk factors for hypercoagulability of blood? These are immobilization, surgery, trauma. Pregnancy is also a hypercoagulable state. Use of oral contraceptive pills, hormone replacement therapy. Malignancy is a major issue, which is a hypercoagulable state. Antiphospholipid antibody syndrome, heparin-induced thrombocytopenia, myeloproliferative disorders like polycythemia rubra vera, smoking and obesity, inflammatory bowel diseases, that is ulcerative colitis and Crohn's disease. These are also a hypercoagulable state. Presence of pacemaker and central venous catheter, as well as nephrotic syndrome, in which the antithrombin 3 protein is lost through urine. These issues are the acquired risk factors for hypercoagulability. While I am mentioning here the most common inherited risk factors for hypercoagulability, these are factor V Leiden mutation, prothrombin gene mutation, deficiency of protein C and protein S and antithrombin, hyperhomocystinemia, and elevated factor VIII levels. These are the congenital or inherited risk factors for hypercoagulability. So what are clinical manifestations of DVT? The DVT patient's leg becomes painful and swollen. It is usually at the leg side, but there can be DVT developing in the upper limb also. There may be signs like warmth and tenderness, dilated collateral veins. Cyanosis can be there in extreme cases of DVT. Gangrene can develop in extreme cases of DVT. Homan sign is positive, which is dorsiflexion of ankle with knee at 30-degree flexion causes calf pain, but this is abandoned now due to fear that it will precipitate a pulmonary embolism. Phlegmatia cerulear dolens, it is a vascular emergency where thrombus completely occludes venous outflow, causing massive limb swelling, ischemia, and venous gangrene. It is seen in cancer, heparin-induced thrombocytopenia, and other hypercoagulable states. So if any patient develops phlegmatia cerulear dolens, it is treated by urgent anticoagulation, elevation, limb elevation, catheter directed, or surgical embolectomy. So you can see in DVT how it looks. The left leg is having DVT. It is painful and swollen, and it is erythematous red, while the right leg is normal. Diagnosis of DVT. Clinical examination is unreliable as DVT, like ruptured Baker cyst, cellulitis, do look clinically same like DVT. So we have to use the pre-test probability scores, lower limb venous Doppler, and D-dimer to suspect DVT. So pre-test probability score, we have well score, lower limb venous Doppler study, which is a sensitive and specific for DVT of 98%. It is operator dependent, and inability to compress the vein with ultrasound probe is diagnostic of DVT in them. While you can see here well score where active cancer, treatment within 6 months or palliation, paralysis, paresis, immobilization of lower extremity are given 1 point. Bedridden status, even for more than 3 days, is given 1 point. Localized tenderness along the distribution of deep veins, entire swollen leg, unilateral calf swelling more than 3 centimeters below the tibial tuberosity, unilateral pitting edema, collateral superficial veins. These are all given 1 points. While alternative diagnosis as likely as more likely than deep venous thrombosis is given -2 points. prior history of DVT and pulmonary embolism is given 1 point. So if the well score is 3 or greater, it is called as high well score. If it is 1 or 2, it is called as moderate risk of DVT. If it is 0, then low risk of DVT. D-dimer is sensitive and negative predictive value is high. Low pre-test probability along with the negative D-dimer has extremely high negative predictive value for venous thromboembolism. But positive D-dimer is actually non-specific as it is positive in many other conditions like fracture, sepsis, pneumonia, CVA. In these issues also D-dimer can become positive. So having a D-dimer negative is a good thing, but if D-dimer is positive, it doesn't mean that you have only DVT and not other issues. Venography was used earlier in earlier days. So here is a video about, I have talked about DVT. Now I will tell something about pulmonary embolism pathophysiology. You can see here, this is our heart and lungs functioning. The heart is pumping blood from aorta. The blood is going towards the peripheral tissue. And from that, it will go to the capillaries and form venules. And from vein, it will come back to the right atrium and right ventricle. Here, it is showing the deep veins of the legs. Due to some bedridden status or fracture, there happens stasis of blood flow and clot is getting formed. This is DVT. And this DVT is slowly progressing. Now some part of this clot is getting detached. This is called as thromboembolism. It is flowing along the way with the blood towards the right atrium. It has come to the iliac veins. Now it has come to the inferior vena cava. From inferior vena cava, it gone to right atrium, right ventricle, pulmonary artery. Now it is in the pulmonary artery. Now here, see, as it is flowing, the diameter of pulmonary artery is decreasing and it is getting stuck somewhere. So this is nothing but pulmonary thromboembolism. The thrombus has become embolic and it got stuck in the pulmonary artery. This is pulmonary infarction. So pathophysiology of pulmonary embolism. The DVT thrombus get dislodged, travels in the vena cava, right atrium, right ventricle, and gets stuck in the pulmonary artery. There is decreased right ventricular outflow, leads to decreased preload to LV and decreased cardiac output, and shock can ensue. As you can see, if the clot is big, it will occlude the pulmonary artery. So if pulmonary artery is occluded, eventually the pulmonary veins will not get more blood. Eventually the blood will come less to the LA and the LV will be underfilled. As the LV starts getting underfilled, the patient's BP drops, and if it is very significant, then patient can land up in obstructive shock also. Sudden development of ventilation perfusion mismatch leads to hypoxia, which triggers tachypnea to compensate hypoxia. So what is ventilation perfusion mismatch? Come to alveoli, which are the basic unit of the lungs. The alveoli are ventilated through the airways with the help of environmental air, while the alveoli are perfused with the help of pulmonary artery. So if there is block in the pulmonary artery, the alveoli are getting ventilated properly, but they are not getting perfused. So it means that the alveoli which is not getting perfused is actually physiological dead for the human body. So this means that suddenly the major part of the alveoli are gone. So this is called as ventilation perfusion mismatch. It means that ventilation is happening properly, but perfusion is not happening. So this leads to loss of lung function, and this sudden loss of lung function leads to hypoxia, and this hypoxia gets detected by the chemoreceptor present in the brain, which triggers the tachypnea and dyspnea. Dilated right ventricle causes right coronary artery obstruction and RCA territory ischemia, which again contributes to failure of RV. Cardiopulmonary collapse from pulmonary embolism is more common in patients with underlying coronary artery disease and other cardiopulmonary diseases. So this point is also important. Suppose a patient is already a patient of chronic COPD or interstitial lung disease, or patient is having underlying LV dysfunction, or patient is already having pulmonary arterial hypertension, if such patients who have compromised heart function or compromised lung function, they can get decompensated even with the small amount of embolism also. So they can get collapse suddenly due to pulmonary embolism. But if we have a young patient with a good cardiopulmonary reserve, they are able to tolerate small pulmonary embolisms also. So what are clinical manifestations of pulmonary embolism? There is sudden onset of dyspnea, hemoptysis. This hemoptysis can happen due to lung infarction, pleuritic chest pain due to involvement of the inflammatory involvement of the pleura, shock, as I have explained, this is an obstructive shock, palpitations due to, as you know, the LV is getting underfilled, so the stroke volume is getting decreased. So in order to maintain the cardiac output, the heart start contracting vigorously in rapid rate. So patient feels palpitation due to that. So these are all issues happening due to acute pulmonary and pulmonary infarction. Vital sign in pulmonary embolism, usually there is tachycardia, heart rate is more than 100 per minute. There is tachypnea to compensate ventilation perfusion mismatch. Low saturation are there because major part of the lung which was oxygenating the blood is lost. So hypoxia develops. Low blood pressure, as I've explained previously. But the important point here is that many times the patients with pulmonary embolism have clear lung in auscultation, and only Krebs develop if there is development of pulmonary infarction. Altered mental status due to hypoxia or shock can be there. So how to diagnose pulmonary embolism? We have ECG, which is the first test done in the hospital. It is the most common finding is sinus tachycardia. Most specific finding and most thought about finding is S1Q3T3 in the ECG, but it is present in only 24 to 26% of the pulmonary embolism cases. The most common finding is simple sinus tachycardia. Patient with pulmonary embolism can have atrial fibrillation, RV strain, development of new right bundle branch blocks, or non-specific STT changes also. So here you can see there is sinus tachycardia, there is right bundle branch block also there. This is S1Q3T3. What is S1Q3T3? See, in lead 1 there is a deep S wave. In lead 3 there is Q wave as well as T inversion. This is called as S1Q3T3 in the ECG, and it is highly specific for diagnosis of pulmonary embolism. There can be sinus tachycardia, simultaneous T inversions in the anterior V1 to V4 and inferior 2-3 AVF, non-specific ST changes, slight ST elevation in 3 and AVF is there. This ST depression and T wave inversion V1 to V4, this indicates RV strain. As the V1, V2, V3 leads are present near the RV, they indicate the RV strain, which is happening due to sudden block in the pulmonary artery. Now we have chest X-ray. Chest X-ray is helpful to rule out other causes of breathlessness like COPD, exacerbation, pneumothorax, pneumonia, pulmonary edema, or ARDS. We have specific signs in the chest X-ray like Western Mar sign, which is regional oligemia, Hampton's hum, pleural base, wedge-shaped shadow, Palla sign, which is enlarged right inferior pulmonary artery. I have taken some pics. See, this is Hampton's hum. You can see this is pulmonary infarction, which has caused a wedge-shaped density above the diaphragm. Western Mar sign, that is focal oligemia. Here you can see, as compared to the other lung areas, this area of the lung is blackish. It means that here pulmonary artery is blocked and there is less perfusion here. That's why it has become blackish. Palla sign, enlarged right descending pulmonary artery, you can see here. Now we come to echo. Many doctors think that echo is the final end in diagnosis of pulmonary embolism. But I want to make it clear that more than 50% patients with hemodynamically stable pulmonary embolism will not have any echo changes. Echo will become abnormal only when there is hemodynamic collapse, or there is some, it is not a rule that every pulmonary embolism patient will have abnormal echo. Those patients who have hemodynamic collapse, they can have RA-RV dilatation, RV dysfunction, McConnell sign, tricuspid regurgitation with high right ventricular systolic pressure, pulmonary arterial hypertension, dilated IVC which is non-collapsing with the respiration. Visualization of thrombus can be also be seen in few cases in the RARV or pulmonary artery, which is called as clot in transition. 1 minute. Yeah, I'm presenting here few echo clips. This is cardiac ultra. Is the echo video visible, madam? Hello.
Yes, it's visible, sir. It's running.
Yes.
Yeah.
Yeah. It is a normal 4-chamber view. I wanted to show to the ones who are not. So we they don't. These are for medical students who don't see much of the echo videos. Here you can see the right-sided chambers are the left atrium and left ventricle, while the left side are right atrium and right ventricle. You can see the right atrium is small. Right atrium and right ventricle are small as compared to the left atrium and left ventricle. But what happens in pulmonary embolism, I will show. Here you can see there is pulmonary embolism has developed. And due to this development of pulmonary embolism, the worm-like structure that is moving in the right atrium and right ventricle, this is clot in transition. This is a DVT clot which is present in the heart. If you see, the left ventricle has become compressed due to high pressure in the right ventricle. This is called as RARV dilatation along with the clot in transition. Here I am trying to show the McConnell sign where RARV is dilated and apex of the RV is contracting vigorously. This is McConnell sign. Next video I want to show, this is parasternal short axis view, where you can see that this blackish is the right ventricle, which is dilated and which is in high pressure. This right ventricle is compressing through the LV, causing it to take a shape of D shape, D. This is D-shaped left ventricle. Now, my slides are visible now.
Yes, visible.
Now come to troponin. Troponin can also be elevated in patients with pulmonary embolism. This troponin is elevated due to RV ischemia, RV strain, and RC occlusion due to raised RV pressure. The elevation of troponin is a bad prognostic marker in pulmonary embolism. Also, the BNP can also get elevated in presence of pulmonary embolism. If any patient with pulmonary embolism has high BNP in absence of renal dysfunction, it is a indirect marker that patient has developed RV dysfunction. ABG will show hypoxia due to ventilation perfusion mismatch, and there will be respiratory alkalosis due to CO2 washout secondary to the tachypnea. So, to diagnose pulmonary embolism, we have to do CT pulmonary angiogram. CT imaging is now standard technique for pulmonary embolism diagnosis. It is widely available and ability to directly visualize the thrombus. Also, it excludes other malignant conditions like aortic dissection, few conditions like pneumonia, serious issues like malignancy, it can exclude. Major disadvantage is radiation, higher cost, contrast-induced nephropathy. So here there are two pictures with CT pulmonary angio. This is, you can see, this is right pulmonary artery. This yellow arrow is showing thrombus. The blackish is the thrombus in the right pulmonary artery. In the right side, you can see the blue arrow is showing, two blue arrows are showing the thrombus. It is a saddle embolus present at the bifurcation of the right and left pulmonary artery. Ventilation perfusion scanning is also one method that we can use where we are unable to do CT scanning. This is a second line diagnostic modality. It is used when due to renal insufficiency or patient already has a contrast allergy or pregnancy. Then where we can't use CT, we can use this ventilation perfusion scanning. How this is done? A radio-labeled albumin infusion is given to the patient's venous system. Then images are seen by the gamma camera to see if any area of lung is not perfused properly. Then a radio-labeled gas krypton is inhaled and patient is subjected to gamma camera to see if any part of lung is not ventilated properly. If any area of lung is not perfused as well as not ventilated, then we call it as match defect. And this match defect is due to consolidation of lung. But if any area we see that it is ventilated properly, but it is not perfused properly, then it is called as unmatched defect. And this unmatched defect is nothing but pulmonary embolism. Here you can see it. The left side is ventilation scan. The right side is perfusion scan. Left side, you can see that the lungs are getting ventilated properly. But if we come to the right side, you can see at the left upper lobe, there is no perfusion. So this is the case of left upper lobe pulmonary embolism diagnosed with the help of ventilation perfusion scan. Pulmonary angiography remains the gold standard for diagnosis of PE, but it is not used because we are using CT pulmonary angio for the diagnosis of pulmonary embolism. Magnetic resonance angiography is also used, but it is to avoid radiation exposure and to avoid contrast in allergic patients. Now, after explaining the pathophysiology and how to diagnose DVT and pulmonary embolism, I will come to the treatment of DVT. The goal of treatment, what is the goal? Goal is relief of symptom, prevention of pulmonary embolism, prevention of CTEPS, that is chronic thromboembolic pulmonary hypertension, prevention of post-thrombotic syndrome, and prevention of recurrent ventricular thromboembolisms. Once diagnosis of DVT is confirmed, immediate anticoagulation should be started. The initial therapy should include heparin, low molecular weight heparin or fondaparinux, followed by vitamin K antagonist, warfarin or acinocomerol, or you can directly start the patient on few neuro-oral anticoagulants like apixaban and rivaroxaban. So how much are the dosages? So if you are planning to give patient heparin, then you should give 80 milligram per kg bolus, followed by 18 unit per kg per hour IV infusion maximum. The target APTT is 1.5 to 2.5 times the control of the APTT for your lab. If you want to give low molecular weight heparin once daily injection, then you should give 1.5 milligram per kg per day. If you want to give twice daily, then it should be 1 milligram per kg per day BD. Fondaparinux, if the patient is less than 50 kg, 5 milligram subcutaneously OD. If patient is 50 to 100, 7.5 milligram subcutaneously OD. If patient is more than 100 kg, then 10 milligram subcutaneously OD. Vitamin K antagonist, that is warfarin and acinocomerol. Once anticoagulation with unfractionated heparin or low molecular weight heparin or fondaparinux is begun, vitamin K antagonist should be started, and overlap should be continued till 4 to 5 days till the therapeutic INR is reached. Once therapeutic INR is reached, that is the INR is more than 2, then you can hold the unfractionated heparin or low molecular weight heparin or fondaparinux, whatever you were using, and you can continue with the vitamin K antagonist. But why this is done? This is done to avoid this. This is warfarin-induced skin necrosis. If you start any patient directly on the warfarin without giving patient any anticoagulation, then this issue can happen. This issue happens because vitamin K antagonists decrease the synthesis of vitamin K dependent factors. There are two factors, protein C and protein S, which are actually vitamin K dependent anticoagulant factors, and their half-life is less as compared to the vitamin K dependent coagulation factors. So if you directly give warfarin to any patient, first the level of protein C and protein S decreases and they get vanished from the blood, which were actually anticoagulants. Then the level of coagulant factors decreases. So there happens a transient state of hypercoagulability of blood if we directly start patient on warfarin. This hypercoagulable blood can cause thrombosis of the venules of the skin, leading to warfarin-induced skin necrosis, which is a dreadful condition. So always remember, whenever you want to start patient on vitamin K antagonists like warfarin and acetrom, you should always overlap them with low molecular weight heparin and warfarin for 4 to 5 days till the INR is above 2. Then you can stop low molecular weight heparin and continue with the acetrom or warfarin. Now come to newer oral anticoagulants. These are the new drugs that have been developed for treatment of DVT and pulmonary embolism. In there we have two sets. First is rivaroxaban and apixaban. Rivaroxaban and apixaban can be started as monotherapy. Directly you can start them without an overlap or initial treatment with unfractionated heparin or low molecular weight heparin. So if you want to start your patient on rivaroxaban, you can give 15 milligram twice daily for 21 days, followed by 20 mg once daily. If you want to give patient apixaban, you should give as 10 milligram BD for 7 days, followed by 5 mg BD for up to 6 months. Beyond 6 months, if you want to continue the treatment, you can give 2.5 BD. But dabigatran has a different mechanism, different protocol to start. First, you have to give parenteral anticoagulation like low molecular weight heparin for 5 days. Once 5 days are over, then next dose of dabigatran you can give according to the renal function of the patient. If renal dysfunction is not there, 150 mg twice daily. If there is renal dysfunction, then you can decrease the dose according to the guidelines. Thrombolytic therapy. So where thrombolytic therapy is indicated in DVT, thrombolytic therapy is reserved for those cases of DVT which threaten the limb or there is iliofemoral DVT. It is given as catheter-directed approach or systemic approach in if catheter-directed approach is not available. Thrombolytic therapy will promote the early recanalization and prevent post-thrombotic syndrome. As I have explained previously, the patient with phlegmasia cerebellar dolens, they require thrombolytic therapy. IVC filter. So where IVC filter is indicated? IVC filter is this mesh-like structure. It is implanted below the renal veins to prevent the development of pulmonary thromboembolism. It is implanted through the right internal jugular approach or right femoral or left femoral approach, whichever is feasible. But it should be looked at, it should be below the renal veins. So where it is used, IVC filter is used when there is contraindication to anticoagulation. Complications from anticoagulation are expected as if the patient is having ataxia and patient has history of recurrent falls. And if you put these patients on anticoagulation, then they can have fall, head injury and development of subdural hematoma or intracellular bleed can happen. In such patients, we should use IVC filter than using anticoagulation. If there is recurrent thromboembolization despite adequate anticoagulation, in these cases also we should use IVC filter. Massive pulmonary embolism, iliocaval DVT, free-floating proximal DVT, or a patient who is having already cardiac and pulmonary insufficiency and will not tolerate any further pulmonary embolism, in them IVC filter can be used. Also, IVC filter you can use in patients with fracture or any other surgery where you have to proceed for the surgery and you have to avoid pulmonary embolism. In them, you can put IVC filter and then take for the surgery. And after completion of the surgery, you can give adequate anticoagulation. Later, you can retrieve the IVC filter as retrievable IVC filters are also available now. So this is how the IVC filter is. It is placed below the renal veins, and it will catch any blood clot which is coming from the deep veins to prevent development of pulmonary embolism. Duration of anticoagulation. So duration of anticoagulation depends upon the risk of recurrence. Risk factors for recurrence are idiopathic DVT, in which we have not found any cause of DVT, hypercoagulable states, as I have explained you, malignancy, elevated D-dimer levels, male sex, and high body mass index. These patients are having high risk for recurrence. In them, longer duration anticoagulation should be used. So usually 3-month anticoagulation we give in first DVT secondary to transient cause, like if any patient has any fracture and has developed DVT, and fracture we have fixed and patient is mobile now, then we should give anticoagulation for 3 months. 6 to 12 months of anticoagulation is given first episode of idiopathic DVT. Indefinite anticoagulation we give when we detect that patient is having homozygosity for factor V Leiden mutation, or is doubly heterozygous for factor V Leiden mutation and prothrombin gene mutation. While long-term anticoagulation can be given in patient with cancer, where till the cancer is active. Once the cancer treatment has been done, then we can discontinue the anticoagulation. Now come to pulmonary embolism treatment. So pulmonary embolism treatment will be tachypneic, tachycardic, hypotensive. So first we should give him support for his physiological system with the help of oxygen inhalation or intubation when it is needed. Hemodynamic support with IV fluids and vasopressors, noradrenaline, dopamine can be given. Anticoagulation with unfractionated heparin, low molecular weight heparin or fundoparinox should be started immediately. And as I have explained in DVT, we should start vitamin K antagonists. If you want to treat on NOAC, we can start NOAC as I have explained in treatment of DVT. Thrombolytic therapy is also to be considered in patient with pulmonary embolism. So what is indication of thrombolytic therapy in pulmonary thromboembolism? Hemodynamically unstable patient with persistent hypotension, BP less than 90 systolic or decrease in BP more than 40 mm of Hg systolic from the baseline due to acute PTE. Or if you have any patient who is on high dose NORAD who is requiring NORAD to maintain blood pressure. These patients are called as hemodynamically unstable patients, and these patients are straight indications for thrombolysis in pulmonary embolism. Possible indications in hemodynamically stable patient with following criteria are the possible indications for pulmonary embolism, like if signs of deterioration appear, like patient develops increasing tachycardia, or there is worsening hypoxia, or there is development of clinical signs of shock, worsening right heart function, severe or worsening right ventricular dysfunction, that is submassive PE, cardiopulmonary arrest due to pulmonary embolism, and after CPR, if BP is more than 90 mm of Hg, then you can give thrombolytic therapy. There is extensive clot burden, that is large perfusion defect on ventilation perfusion scan, or extensive embolic burden on computed tomography, or there is free floating right atrial or right ventricular thrombus, then you should, these are the possible indications of thrombolysis, although they are hemodynamically stable. So what are contraindications to thrombolysis? Intracranial neoplasm, or less than 2 months patient had underwent intracranial or spinal surgery, history of hemorrhagic stroke, active bleeding or bleeding diathesis, non-hemorrhagic stroke within the previous 3 months. So what thrombolytic agents we have? We have alteplase 100 mg intravenously, it is given for 2 hours. Streptokinase 250,000 units intravenously over initial 30 minutes, then 1 lakh unit per hour for 24 hours. Urokinase 4,400 unit per kg intravenously over 10 minutes, then 4,400 units per kg per hour for 12 hours. Now we have our favorite tenecteplase, which is given as IV bolus injection in 6 seconds. If patient is less than 60 kg, then 30 mg, 60 to 70 kg, 35 mg, 70 to 80 kg, 40 mg, 80 to 90 kg, 45 mg. If the patient is equal to or more than 90 kg, then we should give 50 mg. This was my presentation for DVT and pulmonary embolism. I thanks a lot for all for listening patiently. Thank you.
Thank you.